So this morning I spoke about two of the issues about the biology of PSMA that have therapeutic implications. One is the ability to control the degree of expression of the target molecule PSMA by tumor by using anti-androgen therapies, which allows us to regulate or increase the amount of PSMA that's expressed by the tumor cell. The other part I spoke about is when we target PSMA with an antibody or a small molecule ligand, and that targeting agent carries a payload such as a radionuclide, what happens after that payload is internalized into the cell and how that impacts on therapeutic efficacy. If you want, I can go into more detail on each of those. So with respect to the ability to modulate the level of expression of the target PSMA by the tumor cell, when we put a patient on hormonal therapy, which is standard for patients with advanced prostate cancer, you can upregulate the expression of the PSMA molecule on the surface of prostate cancer cells by 5 to 10-fold. That really gives you the ability to deliver a substantially greater amount of the payload to the tumor. And I talked about the kinetics of that process. Regarding the second point on the internalization issue, again, the goal is to target your payload to the tumor cell by virtue of the tumor cell's expression of the PSMA molecule on its surface. And ideally what you want is the payload to be internalized by the cell. And beyond that, you want it not only to be internalized, but you want it to be retained by the cell. Turns out that when you target a payload using an antibody to PSMA, once you internalize it into the cell, it is, for all intents and purposes, there for weeks. Conversely, when you target PSMA using a small molecule ligand, it gets internalized briefly, and then it gets, if you will, regurgitated back out of the cell. And I talked about the process by which that occurs and why that occurs and why it's different between the antibody and the small molecule ligand. Beyond that, I talked about the fact that unexpectedly we found that if we co-target the tumor cells by using a combination of both antibody and small molecule ligand, we can improve the retention of the small molecule ligand by the tumor cell. And by being able to do that, we deliver a dose that is not just the additive amount of the two targeting agents and their respective payloads, but it actually turns out to be synergistic because we get both the benefit of the addition of the two targeting agents and their payloads, but also the added benefit that the antibody forces the tumor cell to retain the small molecule ligand longer. And beyond that, I talked about being able to put two different payloads, one on the antibody and one on the small molecule, which also gives you the ability to develop a more effective therapy. And we have that process in clinical trials now in New York.